Welcome back, ladies and gentlemen, after the morning tea break. To start our next lecture, which is on TAVI, may I invite the two moderators onto the stage, please. First of all, Senior Consultant Cardiologist, Dr. Sepalika Mendis, and Consultant Cardiologist, Dr. Roshan Paranamana. The stage is yours.
Thank you very much, Amara. Good morning, everybody. Good morning, Dr. Fontos.
Good morning.
Can you hear me? Here with me, Dr. Sepalika Mendis, Senior Consultant Cardiologist, National Hospital.
Hi, Dr. Mendis. Hi.
Yes.
Do you mind if I take off my mask? Yes. Yeah. Hi.
Yeah. Let me introduce Dr. Fontos for the audience. And he's the head of Department of Interventional Cardiology, Göttingen, Hungarian Institute of Cardiology in Hungary. And he is a very experienced interventionalist. He has performed more than 10,000 PCIs. And also he has a very interest on structural heart interventions, including valve replacement, percutaneous valve replacement, as well as left atrial appendage closure. Yes, I think we'll straight away go to the lecture, and it's going to be actually an interactive session. So we might disturb you while you are on the lecture.
Okay. Thank you very much for your kind words. And please interrupt me anytime during the presentation. Be as interactive as possible. Just to start, dear colleagues, returning to Sri Lanka is my definite pleasure and privilege. I truly appreciate being given this opportunity. My first visit to your beautiful island took place more than 2 years ago when I visited and tried to help the team of Dr. Sepalika Mendis doing the first procedures. And I still clearly remember those days. We performed 3 beautiful procedures, and I'm very happy and proud that I could be part of that success. This time, unfortunately, I'm only able to join you online, but at least I can tell you that I have no jet lag at all. So today, my goal is to give you an update on transcatheter aortic valve replacement. I chose this sentence as a motto for my presentation today. So the world is moving so fast these days that the man who says it cannot be done is generally interrupted by someone doing it. And it is especially true for the TAVI, the last 15 years of this success story. But let's see how it all started. We know the natural history of this disease, the aortic stenosis, the symptomatic aortic stenosis, and we all know that it is bad disease. The survival of unoperated patients with symptomatic aortic valve stenosis is poor. We lose most of these patients 1 to 3, 1 to 4 years after the diagnosis is done. On the other hand, the survival of aortic valve replacement patients is very similar to the age-matched population. So if we know that the aortic valve replacement is the gold standard, the therapy of choice, why don't we do it always? And the answer is very simple. About 1/3 of the patients who are referred to the surgeons are denied due to old age, LV dysfunction, and comorbidities. And even worse is the situation if you check how we refer the patient to the surgeons. We had a Heart survey. It was done in 2005, and it showed that less than half of the symptomatic aortic stenosis patients were even referred to the surgeons. So clearly there is a huge unmet need in our clinical practice. I think it wouldn't be fair to make a presentation on Tavr with not mentioning our pioneer, Alain Cribier, who has done the very first aortic valvuloplasty back in '85. And he was the first who did the first TAVI procedure in 2002. But we had to wait until 2008. At that time, we had the early safety data available, and we had the very first ESC consensus document. that we could start the procedures. We did the very first procedures in my hospital in November 2008. And later on, we got more and more data on efficacy and the durability of this procedure. And you can see now how it spread over, at least in Europe. In Germany, which is a country who is usually not following the guidelines, but generating the data for the guidelines, so they are always ahead of the rest of the world. And in Germany, the number of surgical valve procedure, valve replacement procedure was stable. It decreased only slightly by 15% over time. And during the same period of time, the TAVI increased by over 2,000%. It's unbelievable. If we look at the data a little bit deeper inside, we can see that there is a slight decrease in number of surgical valve procedures, either an isolated valve replacement or it is combined with the CABG. And also we do less and less transapical valve implantations. And what is increasing enormously is the endovascular, means transfemoral procedures. In my hospital, in the last 12 months, we performed 250 TAVI procedures, and we had only 3 procedures that we had to do through alternative accesses. We did 2 transapicals and 1 subclavian. All the rest, 247, was done transfemorally. Of course, we learned how to deal with suboptimal femorals. We have balloons, high pressure balloons, and we have stents, and we can manage to go through even the tortuous and diseased femorals easily. Similar trend is happening in the United States. The number of surgical procedures remains stable. They do about 30,000 procedures per year. And in the same time, the TAVRs are increasing by 700% over the same time frame. And just a short a slide or two on how we are with the guidelines. And based on the latest European guidelines, we can say that the TAVI is now class 1 indication for extreme and high-risk patient population, with the choice left to the local heart team for intermediate risk patients based on individual patient characteristics. Let's see the AJA guideline, which was also updated in 2017. They had basically the same. For the prohibitive surgical risk patients and high-risk surgical patients, the first choice of therapy is TAVI with class 1 indication. In the low surgical risk patient population, the gold standard is still the surgical valve replacement. In the intermediate surgical risk patient, there is some space for individual patient assessment. We can do surgical valve replacement and also the TAVI. The surgical has class 1 and the TAVI has class 2A indication class at the moment. What do we need to consider TAVI as a gold standard therapy for aortic stenosis? First of all, needed to have a lot of work on completing randomized trials in different patient groups. I will go through it. And of course, there are a lot of specific issues we had to manage to prove that we are at least as good as the surgical valve replacement. They all started with the extreme risk patient population. At that time, the first generation devices were used both at the Cribier Edwards and the CoreValve Classic valve types. And we could prove that in the extreme risk patient population, these are the patients who are not suitable for surgery at all, the prohibitive patients. The transcatheter aortic valve replacement can provide the patients longer life and significantly better quality of life. Then we moved to the high surgical risk patient population with the partner 1A and the US CoreValve pivotal trial with the high risk surgical patients. And we could prove that TAVI is as good as surgery in this patient population. It was still the first generation device for both self-expanding and balloon expandable valves. And then we moved on to the SAPIEN 3, SAPIEN X3, and the core valve CERTAVI trials, and a lot of smaller randomized trials proving that TAVI is as good as surgery, even in the intermediate surgical risk patients. These trials were done with the second generation valves. Most of the time, they were started with SAPIEN X3, but switched to SAPIEN 3, and with the core valve, in the first part of the patients were done with the core valve classic, and then the Evolut was in the rest. And now we even have very promising data on the low surgical risk patients, showing that TAVI is non-inferior to surgery, even in the low-risk patient population. Just to summarize the advantages and disadvantages, surgery is still significantly better in avoiding vascular complications, not a surprise. It's still better in avoiding PVL, and we still have more permanent pacemaker need after TAVI than after surgical valve replacement. On the other hand, we have convincing, strong data showing that TAVI has a mortality, periprocedural stroke, kidney injury, bleeding, AFib advantage over the surgery, and we can show that the transcatheter aortic valve replacement will result in better hemodynamic data, including valve area and bed gradient data, and also the quality of life and hospital stay is better if we choose the transcatheter procedure. Now I'd like to switch to the management of the TAVI-specific issues, which were traditionally considered as the drawbacks of the transcatheter procedure. So let's start with the access site complications. So we know that the vascular complication translate to increase in mortality, and we always have to remember that. So we need to identify the potential risk factors for the vascular injury. Some of them are related to the patient's anatomy, like calcification, tortuosity, vessel size, and the others are related to the device we use. And we cannot deny that we also have a role in avoiding or making vascular complication with our technique, how aggressive we are with the manipulations, and how fast we can realize that we are in trouble and how we can manage these situations. But what we see now is our devices are getting better. The device sizes are getting smaller. The first generation devices were 24 in French size. Nowadays we have 14 French devices available as well. And we also know that we are, as operators, getting better. There is a learning curve in avoiding major vascular complications. So in the beginning, the vascular complication rate in a new center can be as high as 15 to 20%, but after doing like 20 procedures, it will go down to below 8–7%. What is the reason for that? It's easy. We learn how to deal with devices. We know how to select the patients. And also the devices are getting better and better. And the result is that if you compare to the very first trials, the SAPIEN 2B trial, which had the highest complication rate of over 15%, now with the recent generation devices and recent operator experiences, we go down to below 4%. At the moment, we are at that level, which is promising, which is a good result, but our goal is to go down or approach the 0% of major complication rate. Let's see how we are with the periprocedural stroke. The incidence of periprocedural stroke during TAVI has been reduced with the advancement of smaller, softer, and more flexible valve delivery systems, and with increasing operator experience. With the current generation of devices, with the Evolut Pro, the latest data shows that this level is about 1.7%, With the Sapiens 3, it's about 2.7%. So I feel we can be happy with this tendency, but this rate is still 1.7 to 2.7% higher than our goal. We don't want to see any stroke in our patients. We might also be optimistic when we compare the transcatheter to surgical aortic valve replacement data. Apart from the very first randomized comparison, the partner 1A, we got consistent data proving that we can expect to have significantly lower rate of periprocedural stroke with transcatheter aortic valve replacement than with the surgical. Does it mean that we can sit back and relax? Definitely not. We are not fighting against the surgeons, but for our patients. So the goal is not beating the surgeon, but getting as close as possible to 0% of stroke rate. If you look at this meta-analysis of 24 studies in more than 1,700 patients and second-generation valves, we can note that regarding stroke rate, there are only minor differences. I'd underline the excellent result of the transapical Jena valve and the engager valves. They are around 1% in stroke rate, and the surprisingly high rate of stroke rate of the Lotus valve, which was in their trial around 9%, which is really high. The overall stroke rate in this meta-analysis was 2.7%, which is lower than the surgical expected stroke rate. The next issue is the paravalvular leak issue. It's very difficult to judge the PVL. It's a very heterogeneous problem. We have different imaging modalities, transesophageal echo, transthoracic, angiography, hemodynamics. It's very critical at the timing of the assessment, immediately or 10 minutes after, or at discharge, or 30 days, or 1 year. What we know is that if we are using a self-expanding device, it's no use making assessment right after procedure. We have to wait at least 10 minutes because the valve needs some time to expand. The grading scale is also different. What the different centers are using, different valves are used, and even the usage of core lab is not obvious, even in the randomized trials. So if you look at the data from different trials, we can achieve 0 or traces of PVL, which is a good result, in 6 to almost 60% of patients, depending on the trial. And the moderate of severe PVL rate is between 0 and 24%. It's very difficult to judge based on these data and compare them to each other. What we know from the trial is the mortality is increasing by the grade of the paravalvular leak. From the very early core valve data, we had some promising results showing that even the low, moderate, the mild and low moderate PVL didn't translate to increased mortality. What we had to avoid was the severe PVL. The data from the Sapien, the Edwards valve, was a bit more sophisticated, showing that there is a significant difference between the severe and moderate, and even between the moderate and the mild. It's difficult to tell what is the reason for this difference, but if you look at the following slide with a meta-analysis, a retrospective meta-analysis of the data, we can explain some of it at least. They checked not only the Tavr, but also the surgical valve replacement data. And the result is that, first of all, the PVL is equally bad after Tavr than after surgical valve replacement. And the second interesting thing is that in a high-risk patient population, the difference or the influence of PVL on mortality is not evident, but if you go to a lower surgical risk patient population, even the mild can translate to increased mortality. So, and we also know that the valves are not created equal. The best PVL profile of the currently available devices has the Lotus valve. It is a very strong valve. This is why it is an ideal valve to avoid PVL, but on the other hand, because of the same strength of the frame, it is the valve that has the highest stroke rate and the highest permanent pacemaker need. It seems that the Evolut Pro and the Sapiens 3 are the valve types that has the best balance between stroke, PVL, and pacemaker need. And we have the weakest valves, the Accurate Now, and the Portico valves, which has the least strong frame. They have the highest rate of PVL after procedure. So this slide is showing what is our strategy in our hospital. So after procedure, we always do a complete assessment of the PVL using hemodynamics. We always measure not only the pressures, but we even calculate the aortic regurg index to assess it. We do a proper aortography and always do a transesophageal echo. We do the procedures under conscious sedation. We just deepen the sedation for 4 to 5 minutes, and we do a short check on the transesophageal because we feel that it is still the best way of the quantification, localization, and checking the pathomechanism of the PVL. So what we do now, if we have a result of none or traces of PVL, then we are happy with the result. If we have severe or moderate PVL, it definitely needs correction. We never leave a patient with even moderate and severe. If the patient has a mild PVL, then depending on the risk is and the vulnerability of the patient, the aortic regurg, we can decide to accept the result, or we do some or multiple correction steps. The easiest is to do a post-dilatation. If we use a valve-in-valve procedure, we can fracture the frame of the surgical bioprosthesis. We can increase the radial strength of the valve by implanting a second TAVI in the first one. We can choose a device closure, a vascular plug for doing that. Or in some cases, we can try to optimize the position of the transcatheter valve by snaring the valve. The next serious issue is the permanent pacemaker need. For that one, we need to check the predictive factors for permanent pacemaker. Some of them are related for the ECG of the patient, some of them up to the patient's general status, and some of them are dependent on the procedure itself. We cannot really change the ECG factors, and also the patient factors are there, but we have some tools to avoid the procedural factors. And the most important of them is the depth of implantation. We have very convincing data from both the self-expanding and the balloon expandable valves that the depth of implantation is an independent predictor of the permanent pacemaker need after procedure. For the core valve, the threshold is about 6 millimeters. Above 6 millimeters of depth of implantation, the permanent pacemaker need is really high. If we implant it to below 6 millimeters, it will drop significantly. We have the same with the balloon expandable sapien valve. And of course, we also know that the valves are pretty much different in that regard as well. Those valves that has the weakest frame and are implanted to the highest position are the best in avoiding the permanent pacemaker. From that one, the Accurate Now and the Portico valves are the ones that have significantly better permanent pacemaker need after procedure than with the others. But as I mentioned earlier, we have to pay the price of having less pacemaker. These valves are the ones that have the highest rate of PVL after procedure. And finally, what I'd like to tell you is the valve durability, which is probably the most important of all. What we have learned from the surgical studies is that the surgical bioprostheses have a limited durability. This biological valve durability can be altered by structural valve deterioration, non-structural one, leaflet thrombosis, and endocarditis. And these severe alterations can lead to hemodynamic clinical deterioration, and usually it requires reintervention. At the moment, data on TAVI are scarce. This drawing shows examples of structural and non-structural valve deterioration with both surgical and transcatheter aortic valves. The structural valve deterioration includes acquired changes in the prosthetic valve itself, such as disruption of the seams holding the valve tissue together, or the valve tissue to the stent fracture, leaflet calcification, or leaflet tear. Non-structural valve deterioration includes extrinsic disease that processes to the valve, like endocarditis and leaflet thrombosis. Now we have more and more data showing that the durability of our transcatheter valves are at least not worse than the surgical valves. One of the longest follow-up trial is the Notion all-comer trials, which is important for this trial because it enrolled lower risk patients. So these patients live typically longer than the patients in the extreme and high risk trials. So it's more, we have more data, long-term data based on that trial than with the first randomized trials. So this is an all-comer trial, used core valve, transcatheter valve, and it was compared to surgical valves. We used the same follow-up measurements, same echo parameters, and it showed that structural valve deterioration was significantly better with the core valve than with the surgical valves, less than 5% compared to 24%. We have more and more data from the first trials as well, 3 to 5 years of follow-up we have. And apart from the very first Partner 1A trial that compared the TAVI to surgery, it was intra-annular valve, which can provide the same mean gradient and same effective orifice area than with the surgical valve, and it remained the same after 5 years. With
Excuse
the core
me,
valve,
Dr. Pontos, we have only 3 minutes more.
Good. I have not more than 3 or 4 slides. I'm gonna finish in time. So if we check the core valve, the supraannular design trials with the core valve high risk and the Notion 1, you can clearly see that these valves, because of the supraannular position of the valve, could provide better mean gradient and better effective orifice area right after procedure. And this difference remained stable after the 3 and 6 years follow-up period. And this is, I think, my last slide. That shows the ratio between life expectancy and valve durability. So if you check the solid line, which is the man, and the dashed line for women, it shows the life expectancy. This is a slide from the US, a slide from the US. The vertical line shows the age at which the valve durability equals to life expectancy. As these vertical lines and horizontal lines, the color boxes show, the valve durability to life expectancy can be calculated. So if you check a patient at the age of 87, they have in the US a life expectancy of 5 years. For these patients, doesn't matter which valve you use, because the longevity of the patient will be shorter than the durability of any valve. But if you implant the valve to a 62-year-old patient who has a 20-year of life expectancy, in this patient population, you have to choose a valve that has a durability that covers the life expectancy of that patient. So what we see nowadays is that the durability is the last barrier we have to ruin. Because of it's a new technology, we cannot prove that our valve will be durable after 15 or 20 years. Now we have more and more data showing that after 6, 7, 8 years, our results are not worse than surgery, but we will see what the future holds to see that the real durability of our valve is not worse than the best of the surgical valves. Thank you for your attention.
Can I ask a question, Giza?
Please.
Can you hear me? Yeah.
Yes,
We heard that aortic regurgitation after aortic valve implantation, it gives mortality. The mortality is high. The aortic regurgitation is moderate or severe. Native valve, in the presence of aortic regurgitation, do you recommend aortic valve implantation now? Aortic stenosis plus regurgitation.
Yes, if a patient has aortic regurg plus aortic stenosis, then we do the procedure easily without any problems.
Okay, what degree? Do you select mild, moderate, even with severe aortic regurgitation with aortic stenosis?
We do it even in severe. And the critical thing is positioning the valve is a bit more tricky when you treat our pure aortic regurg. But if the patient has also aortic stenosis and the valve is calcified, it can hold the valve very nicely. The problem is that if you have a young patient with pure aortic regurg without calcium in the leaflets and the annulus, in this patient population, putting a valve in is a bit risky. For this patient population, the only valve that has CE mark approval is the Jena valve, which has 3 arms, which will fit in the sinuses. This way, it will hold the valve in place, even if there is no calcium in the valve itself.
Thank you, Giza. Actually, we have many more questions, but unfortunately, we have no time. So we will have to close the session now. Thank you so much for your lecture, and it's very informative. Thank you so much. We would welcome you to Sri Lanka again for as a proctor in our next few cases. Hope you would like to come.
It will be my pleasure. And it was nice seeing you again, Sapalika. Thank you for inviting me.
Bye-bye.
Bye-bye.